anything, you know.
Thank you.
Oh, you're welcome. So you invest $100 this year, and you're going to get, let's say, 10% interest each year compounded. And I know a 10% interest bearing account almost doesn't exist today, but just look at this as an example. Even with simple interest, your $100 in year one grows to $600 in 50 years. Now, that's not a huge growth given 50 years, but remember, all you did was take $100 and put it somewhere else, and you still ended up with 5 times more than you had in 50 years. But with compound interest, which means you also get interest on the interest that's been paid previously, that same $100 grows to $11,700 plus. And so compounding interest means you get paid interest not only on your initial investment, but on the interest that's paid each and every year or portion, however the account bears interest. And you can see that that's why it's called a miracle. That same $100 becomes over $11,000. And again, all you did was stick it in an account and let it sit there. So that's not insignificant. But that also shows you got to do it now as soon as possible to really reap that huge benefit. Here's another example. And if you start saving when you're 25 years old, which many of you are still in that neck of the woods, I know not everybody is, but a few of you are, and versus when you start saving at 35 years. Now you think 10 years, that's not a huge difference. And as you get older, believe me, it's even less of a huge difference. But look at the difference in growth over time. You wait just 10 years to save the same amount on a regular basis, and that 10 years over, you have almost double the amount in that account if you just start 10 years earlier. And again, I'm not sure you completely understand this or understand how it's going to feel later in life, but go talk to some folks who are 55, 60, 65 now and talk to them about what keeps them up at night and what some of the things they worry about, and if planning for their retirement and saving for the retirement, what would they say in terms of advice for you? Because it's very clear, as you can see, that the earlier you start, the farther ahead you will be. Again, another insight. So Susan starts when she's 25, takes $5,000 a year for 10 years. All she invests is $50,000 over a 10-year period. And she ends up with $1.1 million. Bill invests $5,000 a year between the ages of 35 and 65. So he invests a 30 years versus 10. He invests $150,000, 3 times the amount that Susan invests, and yet he only has $540,000 at the end of the time period. Chris starts at 25. Actually, I was wrong. Susan is the one who has $600,000. She only invests for 10 years. But Chris invests $5,000 every year between the ages of 25 and 65. He puts in $200,000. but he's the one with $1.1 million. And so that consistent annual investment, starting young and continuing on, getting into the habit, again, really pays off. He has essentially twice as much money at the end as any of those other scenarios. And again, bank accounts have not been yielding great returns for quite a while. Basically, 2008, 2009 is when those returns. But let's look at the stock market, where many 401k, which is a future savings plan offered by not-for-profit organizations, for-profit organizations, 403bs are what's offered by not-for-profit. Sure, stock markets go up and down. They have risk attached to them. There is reward for risk in stock markets. And you can see here, you know, there were definitely points in time. This area here, this was when the internet bubble sort of crashed, this whole period here. This was 2009, that economic crash there. But you can see if you had put $1 back in 1970, it's grown very nicely over time. And so the more dollars you put in, and that's another thing about particularly investing in the stock market, a lot of investing counselors will tell you, you can't time the market. You can only time how long you're in the market. And what they mean by that is, sure, we talk about buy low, sell high. You know, that's a way to maximize profit. But that's trying to time the market. That means you need to understand, when is the market hitting the low? When is that stock hitting its low? When is it hitting that high? And that's surprisingly, or not surprisingly, but that's very difficult to do. On the other hand, if you invest regularly, consistently, you will over time have significant growth over time. And I'm not going to say that the stock market is the only way to invest money, but when it comes to retirement planning, check with your employer. And anytime they have a matching fund for a retirement, what a lot of hospitals do is they have a basic 403b, a baseline, if you will, that you get just by being employed and working there. And then they'll have a matching program. And Chuck spoke of this last week for the Yale New Haven Health System. You put in 5%, they give you an additional 3%. If you don't put that 5% in, you are literally leaving 3% of your salary in their hands that you'll never have access to. So make sure you find out they have a matching program and at least do that minimum match. Yes, there are all sorts of constraints on when you can take it out, if you can take it out, what happens, what you always, so long as you're the money you put in is always yours. Whether you can take the matching fund or the basic 403b depends on the rules of the contract with the hospital. But again, why leave money on the table? And then again, so you've got student loans to pay, not only from your basic undergrad, but now from Sign. Maybe you have other constraints on your income and what you can do with it. Look at this. You go get a coffee every day, whether from whatever organization you choose to buy your coffee from. $3.50 a day means you're spending almost $1,300 a year on coffee. and it may give you a lot of pleasure. That's fine. I don't mean to take that away. We've got to reward ourselves the best you can. But if you were putting that in an investment over 30 years, you'd have $85,000. You compare $1,300 a year to $85,000 in the future. What can you do with $85,000? A bottle of water. Again, you guys are very good. This is a new generation about not using bottles for their water, but still, $1.50 a day for bottled water is $548 a year. Invest that 5% return, you're looking at almost $37,000 a year. Again, that's, $1.50 a day, some might say is a rounding error. $37,000, now we're talking real money. And the other people I've known who are very smart with money, they'll say, again, you have to pay yourself. And putting money in the bank, putting money in your retirement is what they consider paying yourself first. Number two, take care of the pennies. The dollars take care of themselves, but it's that penny here, penny there, 10 cents there, 15 cents there, $1.50 here, $1.50 there. That adds up over time, that if you actually accumulated that, kept track of it, and used it wisely, you could really make something out of that versus having it be a rounding error. Dolores, would you like to add anything? I'm sure you would, to this discussion, or anybody else for that matter. James, I know you spent a fair bit of time on Wall Street. Do you have any thoughts on this subject?
The road that is less exciting is going to be your better bet. So instead of going out and buying penny stocks, which are, very exciting to watch because the stock's up 4 cents today and it's a dollar stock, that's 4%. But that stock can go down 6 cents tomorrow. So you want to kind of be more focused on either one, blue chips, and or two, I never think it's bad to own Amazon. Now the shares cost $3,000 plus a share, but save up your money and buy a share or two, and because that company is not stopping growing in the United States.
Yeah.
And look at the rest of the world. They're going to be in Europe. They're going to be in Asia. They're going to be in Latin America to a greater extent every year because their model works. Right. So you want to invest in something that to you makes sense. Don't invest in something, a lot of people were out there buying Bitcoin. If you didn't actually understand what Bitcoin did, you could have, lost your shirt. So it's better to look at things that you understand and make sense that are going to just continue to grow. And Carolyn's right. Try to put it away every year, every day. Instead of spending $20 on a shirt, buy it for 10 and you end up saving money.
Yep. And you may not know anything about the stock market. You may be a little fearful about the stock market. I understand that. But I will also say the way the investment houses work now, and I believe Yale New Haven's still with Fidelity. I don't know who Norwalk, Dolores, do you know who Norwalk is with?
It was Prudential when I left, because
Yep.
I still have Prudential.
The state is Prudential, but they have funds where they'll just say, when's your birthday? What's your birthday? And you're going to say, oh, I was born in 1992. So they're going to have a fund that is designed for people born in 1990s that will allow you to invest, and it's a balanced fund. And there's somebody else, a team of people who are sitting around watching the market, planning what to put in that fund, what to sell out of that fund, so that you are in the people born in the 1990s get the best possible return over time. So those blended funds, and that's where mutual funds have come from. Instead of buying a single stock that and again, James likes Amazon. I think that's a safe bet. Berkshire Hathaway, Apple, things like that. But if you don't want to get down in the weeds in to individual stocks. Mutual funds, where there are managers who have expertise and know things, have their whole job is to research to make sure that fund is successful. So you buy funds instead of individual stocks. And that's the way a lot of 403Bs and 401Ks are structured, really around mutual fund investment opportunities.
Yeah, I have to agree with Carol Ann. You have to realize that all these Prudential, TIAA, Kraft, whoever's running the funds, they're experts in their field, and they make a portfolio. They make it up for you based on your year you were born and the year you're going to retire, the predicted performance, and they diversify your funds. And sometimes if you're not that person who wants to watch the stock market and even, every week, every day, because it changes so rapidly, then it's a safe bet to go that way with your job. It is also important to meet with them. I highly recommend you meet with them at least once a year, because I think it's good reinforcement, unless it's a terrible year. And if it's a terrible year, don't panic. It will come back up. You can't be a reactionary when you're in those portfolios. You have to sit on it and trust me, 5, 10, 15, 20 years, like, oh my God, this is looking really good. It really does grow. And the market, I don't know if James agrees, but every 7 years it does that dive and then it comes right back up and it does that dive. So you can't react on it. And the only other thing I really want to add is I highly recommend, my father taught me this. I came from parents who didn't own a credit card and owned everything that they paid cash for. They did not believe in living on credit and having debt. They had a checking account and that was it. I had to force them when they were coming here when I was younger. They used to come out every year on vacation, and I used to force them to get their credit card out. I'm like, don't be walking around with cash. So, I mean, I come from that background that was, very important to live below your means, if you want to say. We all love to spoil ourselves and have nice things and everything. I'm not saying to deprive yourself. That's not good. But I do highly recommend that you learn to live below your means, meaning, don't get into a mortgage that's, the housing bubble, and now you buy a house that's $850,000, but you're making, each, you and your husband or you or whoever you're with or yourself is making $100K a year. What do you think? How is that going to work out? Like, do the numbers, be smart about it. Don't get into that, that highly inflated market, and then you're trying to catch up and pay and work 2 or 3 jobs. That's no life. So don't work to pay a mortgage. Don't work to pay a car. Buy what you can afford and try to live a little below your means, and you will have cash and you'll have that excess money that you like to spend on other things.
My father was the same way. He abhorred credit. He said there were only 2 things you ever borrowed money to buy. And this is a little different if you're in true business where using leverage is important, but in your personal life, most people need to get a mortgage, but you get a mortgage that you can pay off early. You don't get a mortgage you need to strain and worry about. And then education, because he used to say, go ahead, let him try to repossess the education. But there was nothing else ever bought on credit.
And you can't, when you buy property, try to think about 15-year mortgages if you can. Honestly, it's amazing when you do the math and you have a 30-year mortgage. It's horrible. And if you can't initially, then maybe refinance. But I can't. I mean, you guys are coming into that age where you are going to start looking at properties and real estate. So try and head for that 15-year, honestly. It's such a relief to get, like that elephant off your back.
And with property, you buy the worst house in the best neighborhood. You don't buy, in my neighborhood now, some of you, I live on the water. It tends to be a fairly okay investment, but there's a house up the road that they have on the market for $1.4 million. The house on either side of them recently sold for $330,000. Are you going to buy, excuse me, freaking moron is going to pay $1.4 million when they're surrounded by $300,000 houses? I hope they own that house till they die. That's just ridiculous. So again, get a mortgage you don't have to worry about. Limit your credit as much as possible and save for the future, please.
Caroline, I had a question. I think it like will pertain to a lot of us here. Like, I know a little bit about this stuff, so like I would intend on putting in like my 5% and having, say, like the hospital match 3 if that's what their policy was.
Mm-hmm.
But what I wanted to ask was like what your thoughts were on like separate Roth IRA accounts that you could just like add money to as you have it.
Yeah.
And also the concept of like all of us are pretty much have 2 degrees, and for those of us that are under 30, very likely that we have student loans from both degrees.
Yep.
So at what point is the threshold like, so you're putting money away in these accounts and you're expecting, say, like 5 to 8% interest annually compounded, but at what point is it better to just take care of all student loans right away? Like, is it dependent on the rate you have on those loans, or like, because obviously if you're paying 4% in student loans and you're getting 8 back, like at what point would you value attacking the loans first or paying loans over a more extended period so that you can add more to the funds to accumulate?
That's a really good question, Jack. And again, it's highly individualized. And you need to look at the rate of return that you're getting back versus the rate on your student loans or whatever other debt you have. You always need to pay off at least the minimum. You should try probably to get ahead of that too. But I recommend, and I think the Roth IRA, which is outside your employment planning for retirement, is nice because you are paying taxes on it now, so that when you take it out, you don't have to pay taxes. And that's the benefit of when you put your 5% in to the employer plan, that's before taxes. So you're already getting probably somewhere between a 20 to 30% break on in terms of how much it feels like you're putting in, or how little pain it is to put that 5% or even more in. So, but I think you should get into the habit of funding your Roth also. Again, $10 a month, whatever it is, it doesn't have to be big dollars. We've shown that a relatively small amount does add up over time. So get into that habit. And then when you work with a financial planner, when you open a Roth or another IRA, that planner can help you balance how to manage that debt. Maybe depending on what the rates are, maybe refinancing, not for a longer period. Rarely does that work out in your benefit, but for a lower interest rate to refinance might be the smart thing to do. Then sometimes you can almost pay double what you were paying, but you pay it off so much faster because it's going towards principal, not interest. So again, just to sum up, I like the Roth. Get into the habit early, even if it's a small amount. And then every time you get a raise, put the raise money into the Roth so that you don't really feel it. You were surviving before. Now the raise money goes in there, so it's slowly being increased. And work with whatever agency you're doing your Roth or your IRA with. Talk to those financial planners and to get guidance and insight based on your own specific debt income scenario and your goals. You know, again, you can't live a life that's so miserly that it's not enjoyable. There is, in fact, there is in fact more to life than work and savings. But again, you need to have everything in balance, if you will. Does that help, Jack?
Carolyn,
Yes, Eugene.
Yes, thank you.
there is an opinion that one shouldn't pay their mortgages very fast because the explanation is where else can you find the credit 3% or less credit for 30 years?
Well,
And it's
you're
better,
abs.
and it's better to reinvest that money into more, you know, profitable things and just keep paying, or maybe buy another house, rent it out, and then it will pay for itself.
Eugene, that's true.
What do you think? Yeah.
And again, unfortunately or fortunately, depending how you look at it, when I bought my first properties, my mortgage rates were in the 7, 9, and 11%. And those were good mortgage. I mean, I had a good credit rating. Now mortgage rates are in the 3 to 4%, so it's very different. You always have to balance, if you were going to put money in your savings plan, what's the expected return there versus here? And you're right, at 3%, that's as close to free money as that's ever come in my lifetime. That does not mean you buy more house. You still need to buy at a price that makes sense for the future. Don't get caught in a housing bubble that's
Right.
going to collapse.
But inflation,
Right, it really depends.
3%, yes. So, and your payments, monthly payments will not grow, not rise.
Right.
And then, so you are actually essentially paying less with time. So with inflation, so it doesn't pay to pay up the mortgage fast.
But Eugene, what you have then is you have a lot of equity and access to cash to buy extra property. So it's also getting access again to cash in the bank that you wouldn't have had maybe before. Although if you're still paying off consistently, yes, you'll have some equity hopefully in the bank and that you bought, you know, low and the housing market's going up. But you have to think about all that cash equity you have then to pay off other things or do what you want with, whether it's buy another property or whatever. It's having that freedom, I feel, and it might be just something that's drummed into me. And you're right, you're probably, you know, with the market rates being so low now, the mortgage rates, they're really low. But so are a lot of these home equity loans. They're like nothing. I mean, car loans are nothing today. You
Right.
know what I mean? That they're really low. So, but having access, I feel, to that amount of cash in a shorter period of time is some more freedom for me, I feel. And again, it's very individualized. It's how you like to invest your money. It's what you want to do with that money. And make sure that you're not getting, you know, hitting hard with the taxes, that you're doing something else with it, like another property.
Right. It makes sense only if you have investments with bigger return than the interest on your mortgage, of course. Otherwise, yes, I could totally agree.
Yeah, I think it boils down to like the two main approaches that a financial advisor may have when you speak with them is that some will say like, oh, your loans are only at 3%. Like that means every $10,000 you're borrowing in a year, you're paying 300. And they'll think like, I would borrow money at 3% any day of the week because that's a good rate. But other people believe in paying as little interest as possible. So like you could turn $20,000 of student loans into $55,000 of total payments if you set it up over a 15 to 20 year span. But if you were to front load and pay it all in 5 years, you could turn the $20,000 into a total of like $25,000 in payments. So it all is like individualized to certain people's approaches on whether or not they like the idea of paying a higher amount of interest over an extended period of time, or whether or not they like paying as little amount of interest as possible, which would mean paying it in a shorter amount of time. And that would be assuming that like you would only let it extend for 25 years if you knew you had guaranteed return that would be significantly larger than the 3% you're borrowing at.
Right.
Right. It's good to be rich. you pay million up front instead of, paying 2 millions if you're not rich. So for the same property.
It's good to be rich. That is true words never spoken.
Good to be rich and
Although
happy, other than
there are
poor
other
and
things
sick.
like money doesn't buy happiness, although it can certainly solve problems.
And Jack, I just want to go back to your question. I know you were asking about Roth IRAs and the 5% that you get matched then with 3% with free money from the from Yale. But think as well that you can invest more than 5%. It is pre-tax. You seriously, like, just try it. Say, okay, this week I'm going to do 7.5. I'm going to go up to 10% and see what the difference is in your paycheck. You would be surprised how it really doesn't hurt your pocket. It really doesn't, because it's pre-tax. So don't just get married to that 5% that they're saying when you get hired. Definitely do that. But if you can afford to put a little bit more in there, trust me, it'll be worth it in the long run.
And,
I don't know if other people
and
agree.
for somebody like me,
I didn't know they had the option where you could do more than 5.
Oh,
You can
yeah.
go up to 18%.
No, it depends on your age. The IRS limits how much you can put in depending on your age.
Yeah, I think it used to be up to 15 max, but I think they brought it up to 18 or 20. I mean, now I forget.
Again,
I'm sorry.
it depends on your age. They call it catch up. So it's lower when you're young and it's higher when you're older. But the other advantage is by starting something outside of your employer's retirement plan, you have more control over it. You're not bound by the contractual obligations between your employer and the investment group. You get to choose what you want to do with your money sort of fully when you do it in your own, in a plan you've opened. And again, however you start the habit of savings, just start the habit. That's a good habit. That's like exercising regularly. That's like eating a healthy diet. That's all the good things of life. All right, I don't want to belabor this. If you have any questions or need any motivations, feel free to reach out to either Dolores or I. We think it's important because it's certainly our parents helped us through our lives, and I don't want to seem pejorative, but I do think it's an important message that everybody should have. And so we're going to move on to another one of my pet projects, as you know. Now, I understand this YouTube is a little dated. Probably represents when Lil Jon first sold out, but he still has a very important, he and his friends have an important message for us. So watch this, please.
It's coming through really choppy on our end.
I can't hear
sorry.
it, Caroline.
Actually, over here, we're not hearing anything at all.
Yeah, I'm not hearing it.
It might be better to post it in chat and let everyone watch on their own or something. I don't know.
All right, I will. Thank you. Sorry.
All right, guys, I'm going to say have a wonderful day and nice seeing you all.
Thanks, Dolores, for
Hey,
stopping
Dolores.
by. Appreciate it.
Thanks, Dolores.
Nice
Have
to
a good day.
Adios.
Bye, Dolores.
Thank you.
Bye-bye.
All right. All right, so we will move on to our lecture then. How's that sound? Well, if I do that, I gotta do this. Okay. All right, so today's GI Day. We have some review PowerPoints posted about cirrhosis and the liver. We're going to talk a little bit about the liver today, but mostly about some of our other organs. And when we come back for break, remind me, and we can answer some questions about the quiz, because I know there were a couple questions. I know I already looked quickly. They loaded a little faster this time, so I can see there were a couple of questions that I have to make a decision on. But anyhow, so remind me after break, and we can talk about today's quiz. And as a reminder, next week's quiz, it's going to be one of those. I'm going to open it Thursday morning. I'm going to close it Saturday noon. And you're going to take it sometime within that time period. Okay? The other thing was I forwarded the emails about doing the Google poll about attending Thursday's career fair, which you are all going to do. I did not postpone class for my health. I postponed it so you could go to the career fair. Whether you submit your resume in advance, I feel less committed to, but please participate and see how it rolls. I hope last week's talk was valuable for you. And again, if you have any questions, I know I've got some resumes I need to review and get back, and I'm working on those. Anyhow, all right, today's lecture, GI system. So we're going to talk about some malabsorption issues, cholecystitis, pancreatitis. I'm going to ask you to review cirrhosis on your own, and we're going to talk a lot about hepatitis. Okay? Our GI system, so what we're talking about today is sort of the upper GI, our liver. We've got the gallbladder with the common bile duct. We got our pancreas. And those are what we're going to be focused on for the most part today. Other little items that I think are really important to know are the sphincter of Oddi and how that little guy can be quite important, particularly when we're talking about pancreatitis and gallbladder disease. We know the GI system is going to break down food. It's going to try to absorb as many nutrients as possible to help feed the body. We know that the rest of the waste is excreted. We call the food as it's being digested, moving through the GI system, a bolus. And we know that bolus is attacked, if you will, by different gastric enzymes, pepsin, hydrochloric acid, some other things like that to help digest and break it down. When the food enters the duodenum, the gallbladder contracts, the sphincter of Oddi relaxes, and that allows bile to enter the intestine. And again, that bile is helping to add to the digestion process. Other enzymes that we talk about in terms of digestion, again, we talk about bile, and then from the pancreas, it's amylase, trypsin, and lipase. Now, as you probably remember, amylase and lipase are also found in the blood, and you can measure those levels, which can also give you a sense of whether someone's having different GI problems, pancreatic problems, and things like that also. Again, the smallest form of a carbohydrate is glucose. Proteins are reduced to amino acids, and fats get broken down to fatty acids and glycerol. And then these nutrients are absorbed through the walls of the small intestine, get into the bloodstream and get delivered to the cells to help maintain energy. We also have talked a lot about different interstitial fluids. So again, these are fluids that are not in a cell. They are not floating through the bloodstream. This is outside of those two constraints and are, as I often say, not particularly useful to the body when it's in interstitial fluids. When we get onto the kidneys, now again, we've got waste products being absorbed by the kidneys. We've got, and then it gets excreted as waste. And again, that capillary fluid shift works really throughout the body. We've talked about how it works in the lungs, in the kidneys, and even through the periphery as well. When we talk about malabsorption syndrome, it means that for various reasons, the body is not able to absorb the fats, carbohydrates, proteins, minerals, vitamins through the GI tract. And when you have a malabsorption syndrome that doesn't absorb fats, we have what results are light-colored, foul-smelling stools. They tend to be very soft. They tend to be bulky or large. Again, that light-colored, and what's the word for stool with fat in it?
Steatorrhea.
Steatorrhea, that's right. Thank you. If we have a protein malabsorptive syndrome, well, these are folks who are going to have low protein. You're going to look at these folks and you're going to see dry hair or hair loss, fluid retention. We've talked again about how when proteins are low, you end up with ascites, you end up with peripheral edema. And when it gets really in third spacing sort of overall, and what's it called when, and I'm actually having a brain spasm right now. What's it called when you've got literally third spacing throughout the body? Not just, what's it called?
Anasarca.
Anasarca, thank you. Another one of my favorite words. How could I forget anasarca? Right. But again, that's often a sign of protein deficits and or protein malabsorption syndrome. Folks who have trouble working through carbohydrate digestion, folks often complain of bloating and gas and explosive diarrhea. And then other vitamins that are not absorbed or that they are low on, again, anemias, other malnutrition, low blood pressure, weight loss, muscle wasting. So again, each of these are going to have associated signs and symptoms. Celiac disease is a hypersensitivity to gluten, which is found in wheat, rye, and barley. It causes an inflammation of the intestinal mucosa. The villi in the intestine are flattened and are not able to do their work. And all of this causes reduced absorption of nutrients. So again, folks who have a gluten sensitivity are often complaining of gas and bloating, abdominal pain, and are going to, over time, show different malnutrition symptoms as well. Lactase deficiency. These are folks who are not able to process dairy products. Lactase breaks down lactose into simple sugars. In some folks, it manifests itself more in adulthood and causes diarrhea and bloating. Does anybody know a particular group that has a sort of genetic lactase deficiency or lactose intolerance?
African Americans tend to have it more.
That wasn't the group I was thinking of, to tell you the truth, Kristen.
I feel a lot of like my Jewish friends are lactose intolerant.
It's actually Asians. Asians have an almost 40% incidence of lactose intolerance.
Not me.
Okay, Kevin, I'll send you a quart of ice cream. I'm glad to hear that. But
Not me either.
okay. Who's that last one?
That was me, Jack.
Yep. Okay, Irish boy, I got it.
You said about lactose intolerance, so surprisingly they tolerate ice cream well because it's been taken with sugar, so it's somehow been digested.
Oh, thank you.
Yeah.
I didn't know that, Eugene. Thank you.
Makes a lot of sense. My daughter is and can have ice cream, but she's got to take a lactose pill for milk or cheese.
Oh, all right. Thank you. And my niece doesn't do well with ice cream or really any dairy. Interesting. So now your gallbladder. Its real job is to store bile. Before a meal, it's full of bile, so it's about the size of an egg. Once you eat or it responds to signals, it's going to squeeze bile out into the small intestine through the bile ducts. And then the gallbladder becomes empty and flat, and it should be deflated like a balloon. And then slowly it'll fill up again. You know, there's some controversy nowadays on what I call the 5 F's of gallbladder disease, because clearly gallbladder disease can hit anyone. And I think there is a little bit of political correctness in the controversy, but we talk about fair, fat, 40, female, and fertile. And what that means is people who have a lighter complexion, Northern European descent, if you will, have a higher incidence of gallbladder disease. People who are overweight, people who are in their 40s, women have a higher incidence of gallbladder disease, and in particular, when they are of childbearing age or actually pregnant or post-pregnancy. So the 5 F's of gallbladder disease. People who eat high-fat diets. Again, people who are fat, there are some genetic predispositions. People with type 1 diabetes, they not only have sort of a chronically high triglyceride level, but are more prone for gallbladder disease as well. People who trial low-calorie liquid protein diets. I guess high-fat diet was so important, I decided to put it on twice. People who have rapid weight loss. This sometimes increases cholesterol. People who are post-trauma have had surgery, and it is one of the hazards of immobility as well. And again, people who are pregnant or immediately post-pregnant have higher incidence of gallbladder disease. Just to differentiate cholecystitis, we all remember that itis means inflammation. So cholecystitis means inflammation of the gallbladder wall, often an acute infection. Cholelithiasis means there are gallstones in either the gallbladder or the duct system. So what happens? You've got either inflammation or presence of gallstones in the duct system. That's blocking up bile. When the bile backs up, that's can potentially cause pancreatitis or cholangitis because it's backed up through the biliary tract and can occur as a complication of cholecystitis. If you block that bile, if that obstruction is significant enough and is present for a long enough time, your patient will literally look jaundiced. So that it's another thing to look for when you're assessing your patients with suspected gallbladder disease. With gallbladders, it's a sharp right upper, I'm pointing to my left side, I don't know why. It's a sharp right upper quadrant pain that radiates to the right shoulder. It can become more significant after eating a high-fat meal. People are going to have a high heart rate, they'll be diaphoretic, they'll be pale. There is also some rebound tenderness. There may be nausea, vomiting, anorexia associated with this, dyspepsia, flatulence, fever, chills, steatorrhea, and light-colored bowel movements. So there's really quite a number of host of symptoms there. My own journey with gallbladder disease, I was having these attacks, really significant abdominal pain, right-sided, being a terrible self-clinician without a lot of personal insight. I didn't really connect them to high-fat meals, didn't really connect them to anything. All I knew was once I threw up, I felt a lot better. So my life just kept rolling on. And they would happen, first it was every 18 months or so, and then it was every year. I remember I had one when I was living in Australia in graduate school. And I remember thinking, oh dear God, I'm going to die here. And my father, being the cheap bastard that he could be, would not even pay to have my body shipped back home. But, and then one time I woke up in the middle of the night, truly awful pain, started vomiting, and the pain didn't go away. And crawled my way to the ED with my peers and my friends who I worked with, told my story, and they go, oh, your gallbladder, huh? And I'm like, really? You think that's my gallbladder? Again, zero personal insight whatsoever. But the increased heart rate, the pallor, the diaphoresis, the vomiting, the right upper quadrant pain was unbelievable. All those were absolutely true. Diagnostics, sort of good news, ultrasound can be highly diagnostic. They may even if you have got significant gallstones, they can be seen on x-ray, but they'll probably get a ultrasound to get better placement issues. They can do a hepatobiliary scan to see if the bile ducts are patent. You'll see increased white blood cell count. If it's mildly elevated, it's more a sign of inflammation. If it's significantly elevated, it's more of a sign of infection. You'll see serum bilirubin levels increased. Your LFTs will be out of whack. AST, ALT, ALK phos, your LDH will be out of whack as well. And you'll often see serum cholesterol elevated as well. And again, personally, I was never so happy. Had the ultrasound, and a lot of times you find a lot of small stones. And I kept thinking, my God, the worst thing they could tell me is, good news, you don't need surgery. Just with a little bit of diet management, you'll be fine. Because clearly diet management has worked so well for me through the years, right? But luckily they came back and said, man, you have got one monster stone. You got to go to the OR. There's no choice. And I'm like, oh, that was almost good news to me. It was easier for me to go to the OR than to manage my diet long term. Other tests we do, an MRCP, magnetic resonance, don't catch this word here, cholangiopancreatography. This can be diagnostic for gallstones if the ultrasound doesn't give a clear picture. And again, like all MRIs, the visualization and the clarity of these pictures are just remarkable. And they can see blockages in the bile ducts, issues in the pancreas, whether it's cysts or masses. The MRI technology is quite remarkable. Cholecystitis is sometimes, medical management of cholecystitis without gallstones is definitely possible. NPO for some period of time, decreased fat intake, smaller meals makes a big difference. Initially, some intravenous hydration can be helpful. Pain management, antispasmodics or anticholinergics, whether it's atropine or bentyl, antiemetics for symptom control. And I'll tell you, opioids used to be controversial, but no longer. So we do use opioids for pain management in cholecystitis. But again, this is a picture of conservative medical management for cholecystitis. Now, ERCP is another type of test, endoscopic retrograde cholangiopancreatography. I say here, do not use it as a diagnostic procedure. This is an endoscopic procedure where they can literally access bile ducts, the gallbladder, the pancreas, and you can go in and non-surgically remove smaller stones and place stents. It is highly effective for small stone removal and stent placement. But don't please let any, question why somebody would use it as a diagnostic procedure, and let me tell you why. But again, think endoscopy. So again, they're putting a tube down. They're going down the GI tract. They're following all the tracts back through the bile ducts, the gallbladder, into the pancreas. So you're literally threading a I call them wires.
Endoscope?
Certainly, thank you. Smaller than an endoscope, because again, we're going into bile ducts and the pancreas, but they're threading something into those organs. And why I say don't use this as diagnostic, given that we have ultrasound and MRCPs and all for diagnostics, 75% of patients will end up with pancreatitis, especially if they have elevated amylase levels, will end up with acute pancreatitis. Between 10% and almost 15% of patients end up with acute pancreatitis. So here you are trying to go out and remove a smaller stone, which, or if you've got to remove the stone, if you're trying to place a stent, then it may be worth the risk. But given the other alternatives for diagnostic testing, that's a fairly high rate of pancreatitis. And it comes from either injury to the pancreatic ducts or injury due to the contrast that's used in the procedure. And when we talk about pancreatitis, you'll see why that's something to be avoided, if at all possible. So who's at risk for post-ERCP pancreatitis? Well, folks who already have sphincter of Oddi dysfunction. Again, go back and see where the sphincter of Oddi is sort of at the entrance of the pancreas, and it holds back all the pancreas enzymes and things like that. People who are younger, women, and folks who already have a history of post-ERCP pancreatitis. And those are things associated with the patients. Things associated with the procedure, if the endoscopist doesn't have a lot of experience, if it's the common bile duct has a smaller diameter, if it's accompanied by a pancreatic sphincterotomy, meaning they're going to try to make that sphincter a little bigger, if they have trouble cannulating the bile ducts, or if they need to go into the bile ducts multiple times, multiple cannulations. So these are certainly reasonably possible risks for post-ERCP pancreatitis. They've tried to figure out how to reduce how to prevent post-ERCP pancreatitis. They've tried steroids, they've tried antibiotics. Research says doesn't make a difference. They will try to use Voltaren, which is an NSAID. And again, because most of these patients are NPO, it's given per rectum, and that has had some success in decreasing, preventing post-ERCP pancreatitis. Other ways to treat gallbladder disease is whether it's a laparoscopic or a laser cholecystectomy, removing the gallbladder. We know laparoscopic are minimally accessed surgicals. They puncture the abdomen in a couple different places. They inflate the abdomen so they get a better view. They can go in and place a laparoscope, which allows you to dissect the gallbladder away from the liver. Also, especially when they use Lasix, also known as laser, it closes off the cystic artery in the duct, and then they are able to remove the gallbladder through one of those puncture sites. So again, with minimally accessed or laparoscopic procedure, relatively small wounds to heal, relatively little manipulation of the organs in the abdomen, and certainly faster healing time for the patient, a lot shorter time for them to be out of service, if you will.
I have a question.
Yo.
Do you know why it's more common in females?
I do not, no, I do not know. And I don't know, it's sort of this, why it is post-ERCP pancreatitis more common in women. Why is gallbladder disease more common in women? I don't know. I often think with women, but this is my own speculation, Katie, that it's got something to do with different hormone levels.
Yeah, that's what I was thinking. Yeah.
But it's not like I've read that or anything. It's just, what sort of differentiates us.
Yeah, makes sense.
So again, post-surgical procedure, you need to know what procedure was done. That's kind of helpful. Certainly somebody who's had an open cholecystectomy, this used to be quite a sizable wound that was sort of horizontal across the right upper quadrant. That was a good sized scar in the olden days. So you're assessing your patient's level of consciousness, their vital signs. You need to make sure that they understand how important deep breathing is, or let's just give it that umbrella term of pulmonary hygiene. They need to deep breathe, they need to cough, they need to ambulate, they need to use their incentive spirometer. They can't stay stagnant, or we get into all those hazards of immobility. We need to teach them how to splint so that they can cough effectively and help reduce pain. We need to figure out what is going to manage their pain. Watch their incisions, look for signs and symptoms of infection, and also look for signs of bile leaks from those incisions. That's a relatively low incidence, but nonetheless, especially short-term post-procedure is part of the assessment. Other counseling, well, yes, a low-fat diet is probably a better option for most folks, whether they're post-op or going to be medically managed. Weight reduction has shown to be helpful as well. fat-soluble vitamins, bile salts, sometimes enhance absorption and help digestion. Avoid high gas-forming foods, smaller, more frequent meals in the immediate post-op, again, overall, and then post-procedure, limit activities, whether it's an open procedure or even a laparoscopic procedure. You've got to have some precautions in that period immediately post-op.
Question.
Yes.
What does a stent do for cholecystitis? Does it prevent future backup of bile?
That's the goal for the stents, and whether they're going into the bile ducts or into the pancreas, it really is just to try to keep it open so that whatever's supposed to flow out and or flow in has an easier time of it. It keeps the traffic pathways open. Exactly. All right, so our pancreas. Again, pancreas is one of those busy organs. It's both exocrine and endocrine. And what that means is from an exocrine perspective, it's secreting enzymes that break down some of the food, breaks down starches, proteins, and fat. On the endocrine function, we've got the B cells, the islets of Langerhans, that the B cells that secrete insulin and the A cells that secrete glucagon. So it's got a lot on its plate. It's a busy organ, and it's much better when it works well, all things being equal. Acute pancreatitis, you know, has anybody taken care of somebody with pancreatitis yet? Doesn't sound like you've seen it. Man, when those folks first come in, they are in pain. Oh, it must, I mean, they're really in agony. It must be terrible. And there's almost 100,000 hospitalizations a year with acute pancreatitis. So it's not an uncommon diagnosis for sure. And there are almost 2,000 of those patients actually die of pancreatitis. Again, not an insignificant amount. And the result and what causes those deaths is what's called acute necrotizing pancreatitis. What happens is those enzymes that are supposed to digest foods on the outside get stuck in the pancreas and start self-digesting the pancreas, causing areas of necrosis throughout the organ. So again, over time, all cases, that mortality is about 5 to 10%. And it certainly increases significantly if the necrosis becomes infected to almost 40%. So this is, again, not an insignificant diagnosis of patients who are in pain and are terrifically uncomfortable and can have potentially very serious complications up to and including death within the course of the illness. 80% of cases are caused by excess alcohol use and or gallstones. We've got another portion that's post-ERCP, and then there's a variety of other things like different medications, trauma, cancer, and other metabolic problems that can cause acute pancreatitis. But you can see here, there is a fairly significant risk factor there that may be difficult to manage, but can be managed. So acute pancreatitis is graded. It's graded as mild, and good news is this is the majority of cases. There's minimal organ failure. Folks typically recover. They respond well to supportive therapy. This is also sometimes called interstitial pancreatitis. Our severe pancreatitis or necrotizing pancreatitis represents about 20% of our patients. There's more significant organ failure. There are going to be areas of necrosis seen on ultrasound, MRI, CAT scan, whatever diagnostic tool's been used. There is often infection and pseudocyst formation. These patients tend to be much sicker, have much more complicated courses of the disease. They require intensive monitoring and have a much more guarded prognosis over time. The other thing is pancreatitis should be scored in terms of its level of significance or severity, I should say. And so you can gain, on this scoring grid, it's a maximum of 5 points. But again, you can see very quickly, 3 to 5 points, you've got a greater than 15% chance mortality. It's a higher rate of mortality. So we're looking at elevated BUNs, we're altered level of consciousness or Glasgow Coma Scale less than 15, evidence of SIRS, and go back to our first lecture looking for what the SIRS criteria are. A patient over the age of 60, and again, if there's signs of a pleural effusion on chest x-ray. And who would seriously think about how diverse these criteria are, but when you put them all together, it does not paint a good picture for your patient. So again, pancreatitis is inflammation of the pancreas. It is a result of the inflammation, the necrosis, and potentially hemorrhage within the pancreas. Again, we've talked about the mortality rate, and you see other associated signs and symptoms are hypotension, fluid and electrolyte imbalance, and ultimately shock. There is a condition called chronic pancreatitis as well. Over time, that also has a high rate of mortality. But that is a longer and a slower process to get up to the point where mortality becomes a concern, although it is certainly ultimately. What tests are we looking at to assist in our diagnosis of pancreatitis? Well, it's our serum amylase, lipase, trypsin sometimes, serum glucose, definitely liver enzymes and bilirubin levels, and white blood cells or a CBC. You're going to see decreased serum calciums and decreased serum magnesium. And again, we're going to do CAT scans with contrast looking for pancreatitis as well. Our job is to monitor mental status of these patients. Again, remembering back to an altered Glasgow Coma Scale or altered level of consciousness is a significant risk factor. Monitoring our vital signs, looking for elevated temperature, pulse, respiration rates, decreased blood pressure, shortness of breath. Again, the pain can be so significant that taking a deep breath is not easy. That can lead to shortness of breath along with the other metabolic changes of increased temperature, pulse. Again, that severe pain. And this tends to be the left flank. Again, that's where the pancreas is located, radiating to the back, left epigastric pain radiating to the back up to the shoulder. Doesn't get better with vomiting. And again, you'll often find these patients curled up in the fetal position. That brings them some, I'm going to say, limited relief. But when you ask them to roll over and stretch out, that's very difficult for them. Abdomens tend to be firm, rigid. There's a lot of guarding, significant tenderness. And again, given the incidence of excess alcohol use or alcohol dependence, and along with pancreatitis, you have to be concerned about alcohol withdrawal and those behaviors and those signs and symptoms also. So again, just another complication in caring for patients with acute pancreatitis. Patients may have a history of nausea and vomiting. Again, doesn't relieve the pain, but they're still vomiting nonetheless. Have weight loss. Again, when we talked about that rigid, firm abdomen with tenderness, those are signs of peritonitis or an acute abdomen. So you've got to do a very careful assessment. You may see ecchymosis on the left flank, sometimes the right flank, but more often on the left flank. That's called Turner's sign. This is, again, a buildup of blood in that area that's so significant, or pooling of blood in that area that's so significant, you can literally see it through the skin. And again, for folks with darker skin, you still see areas that may turn more purple, but it's a darker, deeper tinge than other areas of the skin. When you see this bluish periumbilical discoloration, that's known as Cullen's sign. Again, all signs of acute pancreatitis. A lot of jaundice. They may have hypoactive to absent bowel sounds, symptomatic of a paralytic ileus, and hyperglycemia, because the pancreas is so inflamed, it can't do the work of getting insulin out and all to help monitor blood glucose levels. Our nursing interventions, you can categorize them using the word pancreas. Manage pain using morphine or Dilaudid are two of the most common drugs. A for antispasmodic drugs, that's your benzol, can be used there. That helps decrease GI motility. NPO or NG suction, let the pancreas rest. Can put the patient on TPN if they need, or if NPO needs to be prolonged, or they need nutrition because they're so have had malabsorption for so long. C, watch calcium, tends to be hypocalcemia, so carefully replace your calcium. Replace fluid and electrolytes. They may have been vomiting, they may have had decreased intake because they've been nauseous and vomiting for so long. Be careful about if they get an NG tube and it's hooked up to suction, now you're removing all that stuff out of the stomach, so you have fluid shifts, electrolyte shifts. You have to monitor your pH again when you hook an NG tube up to suction, because you're suctioning out your acids, if you will. Be concerned about endocrine function. And so monitor your blood glucoses. And again, the enzymes are probably not getting out of the pancreas, so it's going to be very difficult for patients to digest anything they are taking PO. Antibiotics are used when there is a sense that there is an infection beyond a simple inflammation, and steroids can help mitigate inflammation also during acute attacks.
I have a question.
Yes.
I know rebound tenderness is definitely a sign for appendicitis, but
yes,
I don't know if I saw it on here, but isn't it also for pancreatitis?
yes, and it
Okay.
was there, but
It
again,
was? Okay.
with your appendicitis, it's the right lower quadrant. With your pancreatitis, it's left upper quadrant.
With the rebound?
Yep.
Okay.
Maybe I didn't see rebound specifically, but certainly abdominal tenderness, guarding, and rigidity.
Okay.
Okay, hypocalcemia, which we've talked about so often. We looking for tetany. We know Trousseau sign and Bostic sign are ways to assess for that. Again, doing a thorough, complete assessment, making sure your patient's got a fluid resuscitation and their electrolytes are being managed. In the olden days, they used to keep patients NPO for prolonged periods of time. They try to limit that now because, again, we know so much about how the hazards of being NPO are. So if the patient's not able to feed by mouth within 48 hours, they may they'll drop an NG tube to see if that helps. Make sure we're managing their pain. Again, using morphine or Dilaudid are two of the most common medications used to manage that pain. And again, these patients need to be triaged accurately, whether it's appropriate for a general care floor or an intensive care unit. And again, monitoring for other complications. We know alteration in calcium can cause EKG alterations. We know that we've got blood sugar issues without the insulin. Again, and then the risk of infection and superinfection are significant. Pneumonia, if we don't have deep breathing and effective breathing, again, all different scenarios that come in related to those signs and symptoms. Whether they choose to put a patient on prophylactic antibiotics is pretty controversial. You can find research on both sides of that decision. So I suspect it has to do with the clinician's decision. And again, figure out who may benefit from an ERCP. And again, if you need a stent placement or if there's smaller stones blocking, then ERCP might be appropriate. And they've already got pancreatitis, so it may or may not change their perspective. Pancreatic infections sometimes manifest themselves either as an infected abscess or a pseudocyst. They can also end up developing type 1 diabetes, where the work of the pancreas, or I should say the B cells, do not excrete insulin anymore. Lung effusions, atelectasis, particularly on the left side. DIC is rather common with acute pancreatitis, acute kidney injury. Have to monitor fluid status and blood pressure. Over time, shock can be an issue. Talked about paralytic ileus being also one of the things they present with. And again, acute respiratory distress syndrome, which we talked about a few lectures back. That accounts for almost 50% of the deaths that occur in the first 7 days of an acute pancreatic attack. So again, not insignificant. And remember, ARDS is one of those sequelae where you need to treat the underlying disorder to actually get the ARDS resolved. That's ARDS and DIC are just signs that there is something really bad going on in the body, and you got to resolve that before you're really going to get the DIC, the shock, or the ARDS under control. How many slides do we have left? Does anybody know?
We're on 42 out of 98.
All right. And how many left are just pancreatitis? Jesus, I should have just thought, let's just do it. Forget it. We're going to finish out the pancreas. Okay. So there are a couple of different types of chronic pancreatitis. One is chronic calcifying pancreatitis, and the other is chronic obstructive pancreatitis. Calcifying means different areas of the pancreas is getting harder, getting calcium deposits and things like that. And so it's losing its flexibility and it's losing function in certain areas. Chronic obstructive pancreatitis comes from inflammation, spasm, and obstruction of the sphincter of Oddi in particular. And the primary cause of chronic pancreatitis, particularly in older adults, is chronic alcoholism. And so what happens is as a patient gets older, they're not able to process alcohol as efficiently or effectively as when they were younger, leading to chronic pancreatitis. Oh, glad I finished that one. I would have felt really foolish. All right, guys, it's 11 o'clock. Why don't we break for 15 minutes? Let's come back at 11:15 and we'll get started on the liver, okay? Any questions before we break off?
Nope.
Excellent. See you in 15 minutes. Thank you.
Okie dokie.
See you in 15.
Thank you.
Carolyn, you could stop recording.
All right, so let's do a quick review. There were two questions in particular that folks were challenged by. The first one was, this was on today's quiz, the one where the answer was first degree heart block. Somebody want to give me a sense of what was so confounding about that one?
It looked like a normal sinus rhythm, but once you sat back and if you looked at the PR, you knew it was longer than 0.2. But for me, I didn't look at it as being more than 0.2. I just go, oh, it's a normal sinus rhythm. We're good. And then just moved on.
Right. Which I'm going to say, James, goes back to, I said a couple times, you know, you got to be strategic about this. You got to go through the steps. I think I said that at least a couple times. Certainly was in the PowerPoint. And then the next one where I'll probably end up giving points, not because you gave good answers, but just it confounded so many people, was the patient priority one. So you've received change of shift report about the following patients. Which patient should the nurse see first? The first one was a patient who has a sinus rhythm rate of 98 and had electrical cardioversion 2 hours ago. I'm glad to say nobody thought that was a viable patient. A patient with new onset atrial fibrillation, rate of 88, who has a first dose of warfarin due. Why did you like that? Why did so many people like that one?
I
As
like.
Caitlin said.
Sorry, I was between that one and the their defibrillator going off 3 times in the day, but I ended up going with AFib because it was their first dose of Coumadin, and I remembered in our slides you had specified to be careful with AFib and their onset, or being cautious of when it started, because, and I know it was in terms of getting them back to a sinus rhythm, because then their thoughts could go throughout the body. So I think I was just like in that mindset of trying to get them their Coumadin in a timely manner.
Okay. And then a patient with second degree AV block type 1, a rate of 60, who is dizzy when ambulating. And then the next option was a patient whose ICD fired 3 times today, who has a dose of amiodarone due. Why did somebody who liked the ICD one, why did you like that one?
If their ICD went off 3 times and they're definitely not stable, or like they're at high risk for another dysrhythmia.
And okay, and how about the second degree AV block, who's dizzy?
I was going back and forth between those, Carol Ann, and I didn't pick the ICD. Jonathan, I totally understand what you're saying, but in my mind, if the person's got ICD going off 3 times and they're going to give them amiodarone, the reason they're giving them the amiodarone is because the ICD was going off because they have a dysrhythmia. So to me, that made perfect sense. Like, I'm not going to freak out about this guy because I'm giving him the med that is going to address that problem. So I chose the second degree, but it was a hard choice.
Uh-huh. Anybody else want to talk about that? So the way I saw these were certainly the dude with atrial fibrillation, or the dude or dudette with atrial fib, needs their Coumadin. But number one, it's a first dose, and it's going to take somewhere between 3 to 5 days. So whether they get it, let's just speculate, at 8 a.m., 8:30, or 9 is somewhat immaterial. It's important, yes. But again, given that it's a once a day dose, and they probably should be, it doesn't say here, but they should be on heparin anyhow, because we've got 3 to 5 days before we're going to have a therapeutic INR. The AV block, they're dizzy when they're ambulating. Stay in bed till I get back to you. Don't get out of bed without using your call light. That we solved that problem there. On the other hand, the AICD is firing because they're getting tachycardic, they're getting their VTach, and the amiodarone is literally keeping the heart rate down. Amiodarone's a 3 times a day drug, I think, maybe 4, but 3 times pretty definitely. So they really need that. We don't have near as much flexibility with the administration of the amiodarone as we do with either the Coumadin or just telling the patient who gets dizzy, stay in bed for now. Does that make sense?
I mean, I hear what you're saying. I guess a lot of times on units, people still get out of bed and their alarms go off, and the person's going to get dizzy and maybe he's going to fall down and
right. But what are you going to do? I mean, they're still, as soon as you walk out the door, if they're going to get out of bed without using their call light, right, as soon as you walk out the room, they're still going to get out of bed without putting their call light on. Right. You necessarily going into the room isn't going to mitigate that.
I just would check on them first, but that's just me. I mean,
questions like that just trip me up because those are the ones that I overthink, and I'm like, well, we don't know if that patient has been on heparin for the AFib. We don't know if if the patient who's dizzy has been told. So like my mind kind of goes all over the place, and I start to overthink.
Yeah, well, and you're right. We don't. It doesn't say they're on heparin, but we do know Coumadin is a once a day drug. So whether they get it at, like I said, 7:30, 8, 8:39 is, again, maybe not per hospital policy, but less critical than the amiodarone, where we knew this guy's rate is sensitive. He's fired 3 times.
I was thinking risk of critical event when I picked that one, that it was a greater risk of an immediate critical event because 3 things had happened, and the longer that it goes on, the person's at greater risk of sudden death.
Well, it's, you know, and while internal defibrillators are not typically set high enough to cause pain or discomfort. It is, by all accounts, annoying as hell when they fire. Now, when they fire and there was a problematic rate, patients tend to be fairly thankful. When they fire inadvertently, that's annoying as hell, apparently. But so I reckon, you know, that one, that was a tough one. You'll probably end up getting points back on it because it was sort of everybody did bad on that one, or a lot of people did poorly on that one. The first degree, I'm not going to give you anything on because that was just such a long PR interval. But okay, those were the two that tripped the majority up. Okie dokie. So we are recording. We are going to move on to the liver, if that's okay with you guys. I should have said, anything else you want to ask about the quiz?
If it didn't say Coumadin and it said heparin, would that change the answer?
Ooh, interesting question.
Ha ha.
I would say no, because there's nothing you need to do. He's at a rate of 88. He's on heparin. You know, certainly, again, you need to go in and do your assessments to make sure it's the right rate. What, you know, you need to know what his PTT were, things like that. But again, we've got a guy whose defibrillator is going off 3 times, and we got to give him a medicine that he's due to get 3 times a day. So I don't think, good question, but I don't think it would change the scenario at all.
Okay.
Okay, so we're going to, in terms of cirrhosis, again, we talked a lot about cirrhosis in the spring. I posted those PowerPoints, so feel free to take a look over those. You may see some questions. We're going to spend a little bit of time on the function of the liver and hepatitis right now. We know the liver produces bile, which helps with fat metabolism. It works to break down proteins into amino acids. It breaks down amino acids even further into ammonia and urea, which gets excreted through the kidneys. It's got a phagocyte system to remove toxin and break down old red blood cells. The Kupffer cells remove bacteria and other toxins. And then we've got that whole portal circulatory system that brings blood over from the stomach to the liver. And there is a lot of blood in the liver at any given time. Again, it's all moving through. It's not sitting around waiting for, you know, a fourth for bridge or anything, but that portal system does hold a lot of blood. And so that's sitting in there also. It makes albumin. It helps with carbohydrate metabolism and stores glucogen. It stores fat-soluble vitamins, the ADEX, A, D, E, and K. It works a lot on steroid and drug metabolism, particularly barbiturates, opioids, sedatives, and amphetamines. And it also plays an important role in blood clotting, or not clotting, as the case may be. When we have liver dysfunction, whether it's infection or some other inflammation or some other injury, the patients are prone to edema because of decreased albumin levels, vitamin deficits, again, often because of problems with fat metabolism, other digestive problems, decreased clotting factor manufacturing, because there's decreased bile synthesis, that leads to less fat digestion and absorption. Vitamin K is not absorbed as effectively, and clotting factors do not get produced in amounts necessary. The liver, again, clears out a lot of toxins, and when it's dysfunctioning, it's not able to rid the body of those different toxins. We know when there are blood flow problems, particularly with the portal vein, that you get esophageal varices and other blood flow issues. And you get a buildup of bilirubin, which leads to what? When you've got excess bilirubin, what's that lead to?
Jaundice?
Jaundice.
Jaundice, exactly. So interestingly enough, and certainly we're using hepatitis as specific infection titles nowadays, but it really is an umbrella term for a variety of viral, bacterial, and other non-infective causes of liver inflammation. We know hepatitis, so liver inflammation is caused primarily by viral infection, hepatitis A, B, and C. That represents about 90% of the cases. And excessive use of alcohol and other drugs, exposure to different toxins like cleaning solvents, carbon tetrachloride, acetaminophen, which we've talked about the hazards of Tylenol overdose in the past. We have there are other infections such as Mycobacterium avium complex, or MAC, or cytomegalovirus, CMV, which also, because it causes an autoimmune response, causes the body to attack the liver, which leads to inflammation and swelling. And the liver itself, again, we've talked about this with physical exam, the liver itself can get swollen and can become palpable with deep palpation in the right upper quadrant. Again, in most cases, you should not be able to palpate your liver. It should be up out of the way under the ribs. But once it gets inflamed and swollen, and sometimes it even gets a little bit firmer, then you say you can palpate the edge of the liver. And again, I've been very clear, I don't think that's bedside nurse work, if you will. I've never gone out and tried to palpate a liver per se, but again, it is important to know that on physical exam, an inflamed liver, you can in fact palpate it on physical exam. These are a variety of the more common hepatitis infections, hepatitis infections, excuse me. Hepatitis A, it's transmitted through the oral fecal route, eating contaminated food or water. This is what tends to break out in restaurants or from shellfish infections and things like that. Hepatitis B virus is transmitted via the blood. So IV drug use, unprotected sex, and healthcare workers are at risk, high risk for hepatitis B infection. Hepatitis C is also transmitted by blood. So drug use, intravenous drug use, and unprotected sex are the way Hep C is transmitted. Hepatitis D, as in dog, is a co-infection with Hep B, most commonly seen in IV drug users. And hepatitis E is also transmitted through oral fecal routes, usually comes from contaminated water. Knowing how these are transmitted is important for next week. An acute or short-term infection, hepatitis, So let me rewind that. Hepatitis can either be an acute short-term infection or inflammation, or it can become chronic, where it's more long-term and more debilitating with increasing severity of symptoms. People with hepatitis are often carriers and can spread the disease without showing any symptoms. This is one of the reasons why hepatitis B vaccine is really important for healthcare workers. This is a way for us to protect ourselves. You can argue all day long that if you use universal precautions or standard precautions, that you should be well protected, but nonetheless, hepatitis B is a vaccine is another way to really shore up that your own protection. Hepatitis is is reported to public health departments across the country. Those cases must be reported. There is a hepatitis A vaccine for high-risk populations also. And I know they're working on a variety of other both preventions and treatments. So again, viral hepatitis can be transmitted either by blood and body fluids or foodborne transmission. Patients who have hepatitis should avoid medications that are metabolized in the liver. You don't want to put additional strain on a person's liver when it's already got a viral infection. What are the signs and symptoms? Again, jaundice, fatigue, abdominal pain, an enlarged and tender liver, nausea, vomiting, loss of appetite, diarrhea, joint pain. And then this is classic with liver disorders: dark urine and light stools. So the stools become tan, we say putty colored, but the urine gets very dark. We've again talked about jaundice. You've probably seen some jaundice in clinical now. That's the bilirubin accumulating in the skin, usually caused by liver and gallbladder disorders. And again, the liver and the gallbladder in many respects go hand in hand together. Again, you can see jaundice in the skin, in the sclera, that shows up in a couple of different places. Hepatitis A is an acute infection. It can last from a few weeks to several months. It does not lead to a chronic infection. This one used to be called infectious hepatitis, but it's more specifically known as hepatitis A now. And it's a fecal oral transmission. Either somebody didn't wash their hands, if you will, or they were contaminated by shellfish that came from contaminated water. Restaurants, contact with other household members, oral or anal contact with a sexual partner can potentially lead to hepatitis A. During incubation, the hepatitis A is replicating in the liver. Patients are asymptomatic at that point, but they can spread the virus to other people. Then the virus starts being found in bile, blood, and stool. Once they get jaundiced, they're rarely infectious, or they can't contaminate other folks at that point in time. But that incubation period, they are certainly eligible to spread the infection, and certainly later in the phase, again, via different blood and body fluids. They are a risk to other people. Patients don't start seeing symptoms until 15 to 50-day incubation period. So that can be a pretty long time with a lot of high-risk behaviors and activities until then. Symptoms can be mild, almost flu-like, other than the jaundice. They may not necessarily scream hepatitis. It rarely progresses to acute liver problems or cirrhosis. Again, it tends to be an acute problem which will resolve. And again, hepatitis A, once you're infected, you do build up a lifelong immunity. On the other hand, about 30% will have no symptoms, but they are able to pass on the infection. Formal diagnosis comes via a blood test. And again, most people with Hep A will recover without any treatment. It's seen more often in the summer, in the early fall, sometimes associated with cookouts and picnics or raw, poorly washed foods. Unfortunately, again, with the long incubation period, though, you can see infection into the fall and the winter as well. For high-risk populations, there is a hepatitis A vaccine. It's a 2-doser. Your initial vaccination comes with a booster 6 months later. It can be administered up to 2 weeks after coming in contact with a hepatitis A, someone with hepatitis A, and it will increase your immunity for almost 6 to 8 weeks. And again, vaccination is recommended for household members, sexual contact of hepatitis A exposed individuals. It's also recommended for folks who are traveling in high-risk areas. They recommend that you wash all fruits and vegetables carefully with clean water. Avoid raw or undercooked meat and fish. Drink bottled water and use it when you're brushing your teeth. And be concerned about ice in drinks as well. And these are the high-risk areas for hepatitis A infection. I should say these are the risks for different areas with hepatitis A. So children who should receive hepatitis A vaccine, children under the age of 1, lab workers who may come in contact with hepatitis A samples, men who have sex with men, people who are traveling to high-risk areas, people who receive treatment with clotting factor concentrates, people with chronic liver disease, and daycare workers. Do all of those categories, maybe except for the age 1 children, I think it makes pretty good sense why these folks are a priority. Again, your lab workers coming in contact with lab samples, men who have sex with men, traveling, people who receive clotting factor concentrates. Again, most clotting factor concentrates are developed from people donating blood, and while there is testing that goes on, there is still a concern. People with chronic liver disease cannot afford to have another stressor put on their liver, and daycare workers of young children are pretty much put in contact with poop on a really regular basis. Hepatitis B is another very serious liver infection This can become chronic, which means lasting more than 6 months. This seriously increases the risk of long-term liver failure, liver cancer, and cirrhosis. And again, remember, cirrhosis is an umbrella term for permanent scarring of the liver. And what's that a picture of on the right? What 2 things, maybe 3 things, do you note remarkably about that picture?
Ascites
Yes?
and Turner's? Or no, hepatic vein? I don't know.
Yeah, you're on the right track, Katie. Do you remember what that's called?
The Medusa something.
Medusa
Caput.
something, Medusa capitis.
Capita. Yeah.
Yeah, I can't remember whether it's an A or an S at the end, but that's right. And then again, I think there's a fair bit of jaundice there, although even up on the face, it just looks like zombie makeup. But that's an acidic belly and the Medusa capitis. Good job. So hepatitis B is a blood-borne disease. It's transmitted where blood or body fluids from an infected person enter the body of someone who isn't immune. This has an incubation of anywhere from 6 weeks to 6 months before you see the onset of symptoms. The highest concentration of the virus is found in someone's bloodstream. So again, that means IV drug users who are sharing needles, unprotected sex are really high risk behaviors. There are lower concentrations in other body fluids, but still they are potential risk. It can be self-limiting or chronic, but again, going back to what its potential risks are in terms of cirrhosis and liver cancer, that can be certainly quite significant. And so again, the risk factors: unprotected sex with a hepatitis B infected person, IV drug use, sharing needles, living in the same house as someone with HPV infection, or birth to a child. Excuse me, I've got the hiccups all of a sudden. Interesting during a liver lecture, isn't it? Hold on. Okay, I think I'll be okay. A baby being born to an infected mother, high risk occupations, i.e. nursing, or for example, nursing, traveling to areas where hepatitis B is common, and sharing personal items like toothbrushes, razors with an infected person. 30% of people won't exhibit any symptoms. 90% of people develop antibodies and will recover within 6 months. But again, almost 10% develop chronic hepatitis, become carriers, and will be infectious for the rest of their lives. There is a hepatitis B vaccine. Hopefully you all received it. And if not once, if you didn't, titers didn't register after once, you could do it twice and even up to 3 times. You get it at one point, then 1 month later, and then is it 6 weeks or at 6 months? All of a sudden I can't remember, but nonetheless.
6 months.
Thank you. It's a series of 3 injections. Did anybody in the group have trouble getting titers after their Hep B vaccines? I'm a non-responder. I did not grow titers after 3 administrations.
Yeah, I think I had to go back and get something else, even though I got the regular dosage as a child.
Yeah. Again, some of the problems are that it's a pretty hardy virus. It survives outside the body for about 7 days, still being able to cause infection. So this means dried blood spills can still be infectious. Needs to be cleaned with a diluted bleach solution, 1 to 10 dilution of bleach. And you need to wear gloves when you're cleaning up these blood spills. Children who have not yet been vaccinated should be vaccinated. People who are susceptible sex partners of people with the hepatitis B surface antigen should be vaccinated. People who are socially active, not in mutually monogamous relationships. People who are IV drug users, and other people living in the household of HB positive, or I should say antigen positive people, really should have their vaccines. Healthcare workers, public safety workers, people with end-stage renal disease, pre-dialysis, hemodialysis, a large portion of the folks getting dialysis, however they get it, are hepatitis B positive carriers. People with chronic liver disease and people who are HIV positive. So here are again the risk rates around the world in terms of hepatitis B infection in carriers. Hepatitis C is actually relative testing, at least is relatively new, started in 1989. It is a test that's done before blood transfusions and blood products. Before 1989, blood transfusion and blood products were all potentially hepatitis C positive because there was no testing ability. Blood products were screened at the time for hepatitis A and hepatitis B. In the older text, you'll see this called non-A, non-B hepatitis or post-transfusion hepatitis. And what happens is there's a virus, how much of a viral load they get, what genotype they're in, the host, sex, age, race, different genetics, immune response, duration of the infection, and then the environment in which these things are all mixing. Are there alcohols, drugs? Are there different hepatitis B co-infection? Is HIV co-infection? Iron, non-alcoholic something hepatitis. Why can't I remember what NASH is? I'll look it up. I'll get back to you. But again, whether someone's going to become infected takes a variety of factors into consideration. People who should get treatment for hepatitis C and should be, yes?
I just looked it up. It's non-alcoholic steatohepatitis, if I'm saying that right.
Thank you.
You're welcome.
So again, it's folks who have liver disease unrelated to alcohol use. Thank you. People who are hepatitis C RNA positive in their blood, people whose liver biopsies are showing chronic hepatitis with signs of fibrosis, compensated liver disease, compromised platelet counts. So again, probably the other thing is willing to be treated and to adhere to treatment requirements. This is actually a big deal, and we'll talk about this in our last lecture with regards to HIV treatment as well. some of these different treatments, particularly if they require ongoing or chronic treatment, the ability for your client to be consistent and to adhere to a treatment regime is really important, because if they can't or they won't, what ends up happening is it leads to mutation of the virus. So it doesn't become something drastically different, but what happens is it becomes different enough that the treatments we have no longer treat that mutation. And that becomes a bigger problem for the wider population. Does that make sense? Do you understand what I'm saying there? If only half, and we've seen it in bacterial infections also, only half treating an infection leads to mutations, which makes bacteria and viruses even harder to treat with our known conventional therapies. I think that's an okay way to say it. So the goal of hepatitis C treatment is to eradicate the virus. Then along with that, we want to minimize the risk of liver cancer. We want to improve liver damage, because liver does have a pretty strong regenerative properties. We want to slow disease progression, enhance quality of life, prevent transmission of the virus, and reduce extrahepatic manifestations so that there are fewer systemic signs and symptoms and problems as well. In terms of hepatitis C treatments, you're still not sure how to use it in different patient populations. They're still working on what happens if you need to stop the treatment to prevent resistant strains from developing. Again, high drug compliance is required. Further, they're always researching drug-on-drug interactions. And when do you start treatment and when do you wait for treatment are sort of important. Hepatitis D treatment only comes with hepatitis B infection. You don't find hepatitis D on its own. It certainly makes patients with hepatitis B more prone to cirrhosis, and can lead to far more acute, or as I say here, fulminant occurrence of hepatitis. Makes the patients much sicker, if you will. And then hepatitis E is another self-limiting viral infection, except in very limited areas of the world where there's a different genome type found. It is foodborne, and older adults, don't know when we started calling greater than 40 older, males and other immunocompromised persons are at greatest risk. So how do we work with our patients with hepatitis, whatever the source may be? Well, we need to protect their liver. So we need to reduce demands on their liver. That means we need to screen drugs for what is metabolized in the liver. We need to watch their diets. We need to prevent we need to promote physical well-being, prevent complications. We need to make sure they understand the nature of the infection, what the potential risks to their liver are, and what they can do to help protect themselves. We track daily weights, I's and O's, and electrolytes while they're in the hospital. Certainly daily weights, again, really looking at managing their fluid balance and fluid retention issues. Encourage rest, cluster care, and if they are using substances, high-risk substances, let's see if we can't get them into some sort of recovery program, whether it's AA, Alcoholics Anonymous, Narcotics Anonymous, whatever they may be. And then for their loved ones who are trying to help and support them, get those folks in contact with Al-Anon. What do our liver lab tests look like? Again, these are the big cluster of things that are typically drawn to assess liver function. And what you're going to see is, in the most cases, when there's concern about liver function, they're elevated. Total protein should be relatively normal, but again, you check it because we know healing and things like that do better when our protein is within normal limits. You're going to see ammonia elevated also. Now, when we get into bleeding times and coagulation studies, the PT will be prolonged, again, meaning patients are going to take longer to clot, and your INR is going to be prolonged also. One of the few things that declines is albumin, again, related to the liver's role in digesting proteins and things like that. So you're going to see a decreased level of albumin. And what are considered high-risk behaviors? I'm sorry. Well, not following universal or standard precautions, sharing of needles, whether you're, personal hygiene tools, whether you're borrowing somebody's razor, whether you're not, body piercings, earrings, tattooing supplies, things like that. Unprotected sex, multiple sex partners, or anal sex in and of itself is considered a high-risk behavior. And then again, prior to 1992, when they started screening blood for transfusion, unscreened blood transfusions, that was you've heard me often say we've had a and I'll probably end up telling the story again when we do our HIV lecture, but New Haven was primarily IV drug use and sex workers for, at the time it was HIV infection. But we did have a fair number of folks with, we talked about it in pediatrics, the clotting disorder. Help me out. Oh, crap. It'll come to me. We'll keep moving. It'll come to me. It's a leading cause of end-stage liver disease.
Were you talking about hemophilia?
Hemophilia, thank you. Honest to God, it's getting worse.
My neighbor's kid used to have it, so that's why I know,
thank
because
you.
we were extra precautious when they were playing in the yard.
We had a fair number of hemophiliacs who were HIV positive from their blood transfusions and from their factors injections. Hemodialysis is actually a high-risk behavior because of, various and sundry. When they do hemodialysis, the insert is saved for the patient and they're supposed to be cleaned and all, but again, the incidence of hepatitis infection and end-stage renal disease is very significant. Poor hygiene with food preparation with somebody with infection, traveling to undeveloped countries and using tap water, and then other crowded living environments like prisons, dormitories, and long-term care facilities. Our assessment, we need to be vigilant for flu-like symptoms, right upper quadrant abdominal pain, nausea, vomiting. Hepatitis B presents with hepatomegaly and possibly obstruction. And again, obstruction shows up like light-colored stools, dark urine, jaundice, and elevated bilis and liver enzymes, liver function tests. You're going to assess skin color and sclera. You're going to query about muscle joint and abdominal pain. Again, oftentimes these folks feel like they have a flu. There's a general malaise, if you will, fatigue, nausea, vomiting, light-colored stools, dark urine, any rashes or pruritus. One of the medications that can be used for hepatitis B and hepatitis C is interferon. This is one of those immune system altering drugs. It was one of the earliest drugs used for Hep B and Hep C. The side effects often look like even more severe flu symptoms. There can be some hair loss, bone marrow suppression, so low white blood cell counts, and anemia. We need to really watch their CBCs. Interferon can cause significant nausea, so administer it with antiemetics and provide generalized comfort measures. We, of course, are always using contact precautions for hepatitis A and E patients, universal or standard precautions for Hep B, C, and D. These patients need to rest. Bed rest, low activity can really promote hepatic healing. Patient education in terms of risk factors, diet, and how they can protect others around them is really important. A high carbohydrate, high calorie, low to moderate fat and low to moderate protein is the recommended diet for folks with liver disorders. Hepatitis B, C, and D increases the risk for liver cancer. And what we call is fulminating hepatitis has almost 100% mortality, excuse me. The liver cells cannot regenerate, and you can just get increasingly progressive liver necrosis. Hepatic encephalopathy, I'm telling you, advanced liver disease is a terrible way to go. It's really awful. And again, cirrhosis is just sort of an umbrella term also for scarring of the liver. Different risk factors, predominantly alcohol, post-necrotic or hepatic cell necrosis, biliary caused by chronic biliary obstruction, and cardiac chronic heart failure, which, again, liver congestion, again, that either your left-sided heart has such significant dysfunction, it's backing up the right side, and the right side ends up with liver congestion and just becomes a whole progress of things. We already talked about what the blood tests that we send to assess liver function are. A liver biopsy is the most definitive way to diagnose cirrhosis or scarring in the liver. They can also, an EGD, an upper endoscopy, if you will, upper GI endoscopy, can detect esophageal varices, which of course we know form again from that liver congestion and is one of the biggest risks in liver failure. That upper GI bleed, if one of those esophageal varices gets nicked or starts to bleed, you have got yourself one hot, bloody mess in the face of somebody who may be a hepatitis carrier on top of it. So that's a significant risk for sure. We're always monitoring vital signs. Again, what is asterixis, my friends? One of my favorite words.
The hand flapping.
Exactly. Again, comes along with hepatic encephalopathy, asterixis. They're not able to keep their hands straight out and bent back. Look at my mirror. Other same symptoms. You know, the symptoms are very consistent with liver disorder. And again, tracking those coagulation studies are really important. We've talked a lot about petechiae, ecchymosis. These folks are often at greater risk for nosebleeds, hematemesis, a lot of dependent edema, ascites. Portal hypertension, again, that liver congestion and a lot of blood, even more sitting in the liver, in the esophageal varices and all, ascites, coagulation defects. I'm starting to repeat myself here, sort of thing. Hepatorenal syndrome, one of the things that happens, there's so much circulating volume literally stuck in the liver and the portal system. There is sometimes decreased blood flow to the kidneys, and we know how much the kidneys hate that. We know with ascites, there's a whole slew of extracellular fluid, interstitial fluid building up. When we're managing, particularly on the fluid side, we want low sodium, lower protein, moderate fat, higher carbs, high calories. Watch your vitamins. We do use TPN a fair bit with folks with liver failure. Sometimes they're so nauseous they can't keep food down, and the TPN also helps with a precise balancing of nutrients. Significant ascites can be tapped via paracentesis, and excess fluid can be drained off. The esophagogastric balloon tamponade, again, we talked about that in the spring with esophageal varices, where you inflate, you drop a special kind of nasogastric tube, you inflate a huge balloon that just applies pressure to those esophages to keep them from popping and bleeding. And folks with cirrhosis need to leave alcohol behind. They need to stop drinking. They can't handle it anymore. They can't process it anymore. And it's just causing increased liver damage. Endoscopic band ligation, that's again trying to band some of the esophageal varices. It's an IR, interventional radiology procedure. We're always, when we've got bleeding varices, we're looking for hematocysts and melena in the stool. We're looking for to diagnose, we do it via endoscopy or CAT scan, ultrasound. We often have oxygen on the ready, IV fluids, potential blood infusions, balloon tamponade. Again, anything to stop those varices from bleeding or from leaking. Other nursing diagnoses we see with liver failure in general are altered mental status, ineffective breathing pattern, excess fluid volume, risk for impaired skin integrity, risk for infection, chronic pain, and risk for imbalanced nutrition. And again, any of those risks can potentially become real problems as well. And that's why we're sort of always assessing patient status. The other picture was much better of that Caput medusa, with those dilated veins on the patient's abdomen. We talked about the TIPS procedure, transjugular intrahepatic portosystemic shunt. This is where they literally place a blood flow shunt from the esophageal varices so that it bypasses, or some portion of that blood bypasses and can drain out of the varices and decrease their swelling significantly. It does definitely help mitigate the risk for esophageal varice bleeding. And again, the ultimate treatment is liver transplantation. Hepatic encephalopathy, again, minor mental changes, some motor movement changes as well. You get really full-blown changes in level of consciousness. They can be initially confused right on to difficult to arouse, checking for asterixis. Initially, reflexes can be hyperactive, then decreased response or flaccid. These patients are often at a greater risk for seizures and coma as well, and it's related to a buildup of ammonia and other toxins as well. How do we get rid of excess ammonia in the body? What medication do we use?
Lactulose?
Lactulose.
There you go, lactulose, beautiful. And hepatic coma is, again, that increasing, or should say further decreased level of consciousness. Patients at this point are very jaundiced. Even if you could rouse them, they have no appetite at all, even beyond the risk of nausea and vomiting. Significant coagulation defects, renal failure, maintaining electrolytes is a challenge. These patients are really very sick and quite obtunded. All right, and that's it for our lecture today, but I have something else for us to do. How do you like that? Okay, so I'll certainly post the Jeopardy, and I want to do it in a more organized fashion. So I'm sure I'm not going to be able to stop everybody from calling out the answer, and that's cool too. But if you want to type your answer into chat, that's great also, but we're really doing this just to sort of review content and things like that. So let's look at today's categories, shall we? I agree. Let's look at today's categories. So our first category is hepatitis, pancreas, GI assessment and procedures, alcohol, gallbladder, and potpourri.
Potpourri for 200.
Potpourri
100. 100.
100, start at the top. Okay. All right. 2 or 3 soft bowel movements a day.
What is diarrhea?
Oh, no. Oops, my bad. Christ almighty.
Is regular?
Yeah. Yeah, that's what I was gonna say, regular.
No. What is the expected action of lactulose?
What is reducing ammonia?
Well, no, that's the question. 2 to 3 soft bowel movements a day. That's what you want lactulose to do. That's how your lactulose is only working when the patient is stooling. So you give them the lactulose, it stimulates the stooling, and that's excreting the ammonia. So you don't want them to be pooping all day, all night, but if you're getting 2 to 3 nice soft bowel movements a day, you can be pretty sure your lactulose is working. All right. What's our next one? Stay in potpourri or go for something else?
Go for booze for 500.
Okay. Oh, for 500. Dietary restriction of this is the main treatment of ascites to reduce fluid retention.
What is sodium?
What is sodium?
What is sodium? Woohoo! Beautiful. All right. Was that Katie who or?
I said, what is sodium?
Okay, so you get to pick next one, please.
Pancreatitis, 500.
Oh, she's going for the big bucks. Pancreatic enzymes that aid in the digestion of carbohydrates, proteins, and fats.
Amylase and lipase.
Amylase.
Trypsin.
So let's check. What are amylase, trypsin, and lipase? I'll still give it to you. I think that's a good, nicely done. Was that Robin?
Sammy hit that one first.
Sammy, sorry. Okay, Sammy, go
That's
for
all right.
it.
Oh, dang it. I have to choose now. We'll go with pancreatitis 400.
There we go. Shock and multiple organ failure.
What is systemic inflammatory response?
Somebody want to try another one?
Multiple organ dysfunction syndrome, MOTS.
Now we're in the pancreatitis subject.
What is what is it called?
A necrosis thing?
Yes, sclerosis. Hold on, never mind.
Necrotic pancreatitis. Let's go to our response. What are potential complications of acute pancreatitis? You were on the right track, Jonathan. You were. So I'm going to let you pick our next one.
GI assessments and processes for 300.
All righty. Involuntary flapping of the hands seen in stage 2 encephalopathy.
What is
Asterisk.
asterisk?
There we go. What is asterixis?
Asteristics.
Yeah, close enough. Half the time, half the time I mispronounce, and the other half of the time I can't remember a word. So, you guys are, you're hamstrung from the get-go. All right. Okay, pick another one.
Hepatitis 200.
The number of weeks before a person with hepatitis A shows signs and symptoms.
Wasn't it up to 50? It can take up to 50 days because the incubation period is long.
Okay. Let's see.
So
What is two? You were right, though. It was 2 weeks to 50 days. You were right. So I'm going to give that to you too. Okay, Jean, you pick the next topic.
I would choose ETOH for 400.
Patients with cirrhosis are at risk for bleeding because of the liver's decreased production of this.
What is vitamin K?
Is vitamin K. It needs vitamin K to produce this.
Oh, sorry.
Yeah, but kind of close. Kind of close. Pick another one.
We'll do pancreatitis 200.
Progressive inflammation with fibrosis tissue, increased pressure and obstruction of the pancreatic and common bile duct.
what is chronic pancreatitis?
Had a 50-50 chance there. Let's see. Well done.
Woohoo.
Okay, Kate's next one.
Let's hit the gallbladder.
I was just going to say, gallbladder's not getting any love here. Right upper quadrant pain radiating to the right shoulder, nausea and vomiting.
What is cholecystitis?
Cholecystitis.
What are signs and symptoms of gallbladder disease? I will take that. Thank you very much.
Go ahead, Sammy.
Let's do hepatitis for 100. Alex.
Hepatitis virus is spread via sexual contact and needle sticks.
Hep B. What is Hep B?
Hep B.
What is hepatitis A?
No, Hep A is fecal oral.
No, what is Hep C?
Hepatitis B or C.
B or C.
Okay.
Oh,
All
okay.
right. What are hepatitis B and C? I didn't mean to cut off the chair. Okay. I heard Linda there. Let's give Linda a chance to select.
Hepatitis 300.
The most common cause of liver cancer.
What is hepatitis?
I think you need to be more specific.
B?
It is hepatitis C.
Yeah.
For common.
Hepatitis for 400.
Malaise, anorexia, weight loss, nausea, vomiting, abdominal discomfort.
What are signs and symptoms of hepatitis?
What are signs and symptoms of acute hepatitis? Beautiful. Kristen, why did it do that?
What are the lab values that you have to look for in hepatitis or that are elevated?
Liver function test.
Liver function.
Okay. What are common lab tests to evaluate liver function? Again. Beautiful. Sorry, I didn't mean to choose that one. Kristen, you can choose again.
Let's get drunk and do alcohol for 300.
The most important intervention for patients with alcohol-related cirrhosis.
What is abstaining from alcohol?
What is alcohol abstinence? Well done.
Oh, sorry. Potpourri 500. I don't even know what this category is, but
It's whatever came to my mind on the topic. The precautions used to prevent spread of hepatitis viruses.
Or universal precautions.
What are universal or standard precautions? We are on a roll here. Next one.
Let's have booze for 200.
Fluid that accumulates in the peritoneal cavity with liver failure.
What is ascites?
Ascites.
Nice.
Round it out with.
Round it out.
Yeah, alcohol.
The most common cause or source of bleeding in patients with cirrhosis.
What are esophageal varices?
What are esophageal varices? Beautiful. Jean, I heard you. Why don't you pick one for us, please?
Potpourri 400.
Fecal oral.
What is Hep A?
Or Hep E.
Or transmission of hepatitis A?
How is hepatitis A spread? Kevin, you take a chance here.
Sure. Pancreatitis for 300.
Recurrent attacks of severe upper abdominal and back pain accompanied by vomiting.
what is chronic pancreatitis?
Common symptoms of chronic pancreatitis. Beautiful. Katie?
Gallbladder 400.
Inflammation versus calculi.
What is cholecystitis?
Versus cholelithiasis.
Versus cholelithiasis. Yeah.
What's the difference between cholecystitis and cholelithiasis? Nice. Jonathan, I heard you. Why don't you pick one for us, please?
Let's do GI assessments 400.
Frequent frothy, foul-smelling stools seen with chronic pancreatitis.
Diarrhea.
Rita?
There you go. Nice. All right, James, your turn.
Potpourri for 300.
An MRI, CT, abdominal ultrasound, MRCP, amylase, and lipase.
What are diagnostic tests for pancreatitis? Or no, cholecyst, yeah, gallbladder.
Judges?
Close?
Yeah. Yeah. And you know what? You're not completely wrong. They would do those for probably liver, gallbladder, and pancreas, to be honest with you. All right, next one.
You pick, Carol Ann.
All right, let's go gallbladder for 500. Give anticholinergic meds to decrease secretions and counteract smooth muscle symptoms. Spasms, smooth muscle spasms. the response. Conservative medical management of cholecystitis. So instead of taking them to the OR, try to manage the spasms. That really was a $500 worth question, wasn't it?
Guess so.
Yeah. Hepatitis for 500. AST, ALT, albumin, and PT.
What are liver function tests?
What are common labs to test liver function? There you go. Close out pancreatitis. The duct is obstructed, enzymes back up, causing autodigestion and inflammation.
What is acute pancreatitis?
What is acute pancreatitis?
GI 500.
Okay. Patients should empty their bladders before a liver biopsy.
What is
true, right?
Pre-operation instructions. I don't know.
Yeah, what is true? I went for even something more simple, Kevin. Yeah, you don't want a big inflated bladder getting in the way of that big ass needle coming in. Okay. Potpourri. The medication used to lower serum ammonia levels in patients with liver failure.
What is
lactulose?
Very good. Gallbladder, the 5 F's of gallbladder disease.
What is fat?
Fair, female,
fair,
Female.
40.
Fertile.
And fertile. There you go. Fair, fat, 40, fertile, and female. Beautiful. And GI assessings. This procedure has a high risk of causing pancreatitis.
What is ERCP?
What is ERCP? GI assessments for 200. The surgical procedure to remove the gallbladder.
Cholecystectomy.
Laparoscopic.
It could be open. I would have given it to you though. And to clear the board, the color of stool in gallbladder disease.
It's gray.
Right?
clay colored.
Putty, light, gray. I would have given it to you. All right, now Final Jeopardy. Did I have a Final Jeopardy? I don't know. I do. The bluish flank discoloration that indicates blood-stained exudates that have seeped from the pancreas due to the severity of the disease process.
What is Turner sign?
Or is it?
What is Turner sign?
Which one's color?
Say that again.
Cullen's is the bluish periumbilical discoloration
Okay.
versus Turner's, which is the ecchymosis.
Got it.
Okay, so I will post this, open it up for you guys to review it. Again, next week's quiz is going to be an open time period where you're going to be on your most highest ethical behaviors. And so I'll open it Thursday morning for those that want to get it done before Thursday's events, and I'll keep it open till Saturday at noontime. If you have any questions, you know where to find me. Do you have any questions now?
Carolyn, Thursday starts at 12 noon, is that correct, or it starts earlier?
You know, honest to God, James, I should know the answer to that, but I don't. I need to look and see. But I do know that the, remember, after the fair, the career fair, we then have postcards from Reality, which is also a very cool event. So please make sure you you participate in that. Yes, James, the career fair starts 12 p.m. to 5 p.m. And postcards, I believe, starts pretty much right after that. Which is postcard
when are we
starts
gonna have
at
the lecture?
5:30. What was that?
When are we gonna have the lecture?
The next week. So 5 plus on November 12th. Instead of the final exam, we will have the lecture on the 12th.
Oh, that's right, because you the schedule was changed. So next week we technically don't have class.
Yes, that is correct.
How does
Thank you.
cards work? Is that like each person will be in a room and you can drop in and ask questions?
Exactly right. Yes.
Is that
And how
before
long
the
does
career
it-
fair or after?
Oh, it's after the career fair starting at 5:30. And it's all signed graduates to tell you what their transition was like from student to new graduate to employed professional.
Sounds good.
Any other questions about anything? All right. You know where to find me. Thanks, guys. Have a great
Thanks,
day.
Carolyn.
Stay
You
dry,
too.
stay warm.
Thank